Chapter 10, Treatment of Pain and Migraine Headache. In this lesson, we're going to learn about the terminology associated with the treatment of pain and migraine headaches. Make sure to review the chapter key terms at the beginning of the chapter. It's definitely some important information in there. Acute pain is triggered by an injury, burn, infection, or some other stimuli and is self-limiting. Chronic pain may persist for years and is inadequately controlled by pharmaceuticals or other pain management therapies. Neuropathic pain is associated with a nerve injury caused by trauma, infection, or chronic disease such as diabetes. So you'll hear a lot about patients with diabetes have a neuropathy. Physical factors can influence a person's tolerance for pain. It can influence the treatment outcome. Pain may be referred to the site where pain symptoms are most strongly felt, may be different from the origin of the painful stimuli. Pain can be triggered as part of an immune system response to fighting a disease. Conditions that produce pain, non-susceptive origin, inflammation, arthritis, low back pain, headache, burns, and trauma. Neuropathic origin, diabetic neuropathy, phantom limb shingles, and trigeminal neuralgia. Conditions that produce pain of nociceptive origin, inflammation, arthritis, low back pain, headache, burns, and trauma. For neuropathic origin, diabetic neuropathy, phantom limb shingles, and trigeminal neuralgia. Nociceptors are thin nerve fibers located in the skin, muscle, and other body tissues that carry pain signals. The transmission of the pain message begins with activation of nociceptors in peripheral tissues. The neurochemistry of pain, cytokines produce pain-causing inflammation. Phospholipase A2 stimulates arachidonic acid release. Cyclooxygenase increases prostaglandin synthesis, an important mediator of pain. Histamine and bradykinins produce inflammation, vasodilation, and pain. Serotonin stimulates nociceptors and causes pain. Glutamate enhances response to painful stimuli. Substance P produces pain sensations and controls pain perception. Neurokinin A is a neuropeptide, pain perception and transmission, pain sensations. GABA is inhibitory on nociceptors, reducing pain sensations. Endorphins and enkephalins and dynorphins are opioid peptides released by the body in response to painful stimuli. They bind to opioid receptors in the brain and spinal cord and block or dull pain sensations by inhibiting release of substance P and glutamate. They act like natural painkillers. For the medications used to treat pain and migraine headache, we're also going to learn to classify the medications used in the treatment of pain and migraine headaches, describe mechanisms of action for each class of drugs used to treat pain and migraine headache, identify significant drug look-alike and sound-alike issues, identify warning labels and precautionary messages associated with medications used to treat pain and migraine headache, and identify significant drug interactions. Drugs used to treat pain. Opioid is a term used to describe a drug that acts like morphine, whether naturally occurring or synthetically derived. Opioids and opioid drugs produce analgesia. The response to opioid analgesics is less with neuropathic pain than with nociceptive pain. So basically, if you're taking opioids for neuropathic pain, they're likely not going to work very well. Mechanism of action of opioids, they bind to opioid receptors located in the dorsal route of the spinal cord, brainstem, thalamus, hypothalamus, and limbic system. There are several types of opioid receptors, mu1 and mu2, kappa 1 and kappa 2, and kappa 3, and delta 1 and delta 2 receptors. The effects of opioid receptor binding. So, mu receptor stimulation produces analgesia, euphoria, respiratory depression, pupil constriction, decreased gastrointestinal motility, and physical dependence. Kappa receptor binding produces analgesia, sedation, pupil constriction, dysphoria, and hallucinations. Delta receptor stimulation produces analgesia and decreases contractions of smooth muscle. Opioids are characterized according to their action at the opioid receptor. Agonists activate mu, gamma, or delta receptors. Antagonists bind to the opioid receptor but do not activate it. Mixed agonists and antagonists. Sometimes the opioid behaves like an agonist and sometimes it behaves like an antagonist. Agonist activity is exhibited if the patient has had no recent exposure to an opioid agonist. So they're opiate naive. If the patient is currently taking an opioid agonist, the mixed agonist and antagonist exhibits antagonist activity. Mixed agonists relieve pain but have less respiratory depression and addictive potential than opioids. So that is great. Respiratory depression is basically like, you take these kind of medications and you just fall asleep and you never wake up again. The pharmacokinetics of opioids, the average onset of action for orally administered opioids is approximately 30 minutes. So it's taken or given to the patient and it should start working in about 30 minutes. The peak effects are achieved between 30 minutes and 2 hours. So the patient could receive the peak effects of the medication at that 30-minute mark when it's onsetting. The duration of action for immediate acting opioids is between 2 and 6 hours. The duration of action for controlled release opioid analgesics may last for up to 72 hours, like the fentanyl patches. Adverse reactions for opioids, nausea and vomiting, sedation, dizziness, respiratory depression, constipation, tolerance, and dependence. Then we have the look-alike, sound-alike drugs. Opioid antagonists are indicated for reversal of respiratory depression caused by opioid use. Respiratory depression may be produced by drugs administered during surgery for general anesthesia or may occur in infants born to opioid-dependent women. Naltrexone is also indicated for the treatment of opioid overdose and the management of drug and alcohol dependence. Opioid overdose is a public health issue. Opioid use and opioid overdose is epidemic. Americans that died from an opioid overdose exceeded over 100,000 annually in 2021. Naloxone is an opioid antagonist that is available for emergency use to reduce death due to opioid overdose. So it's available as a nasal spray or an injection that you can give to somebody if they are overdosing to reverse that effect. Opioid agonist therapy is an effective treatment for opioid use disorder involving opioid drugs such as heroin, oxycodone, hydromorphone, fentanyl, and Percocet. Therapy involves taking an opioid agonist such as methadone or a mixed agonist such as buprenorphine, and the brand name for that is Suboxone. Non-opioid analgesics, so non-steroidal anti-inflammatory drugs, NSAIDs, and aspirin are widely used in the treatment of pain with or without inflammation. NSAIDs and aspirin have analgesic, anti-inflammatory, and antipyretic properties. An antipyretic is a drug that is capable of reducing fever. The mechanism of action and effectiveness of NSAIDs are similar to salicylates, like aspirin, but NSAIDs have greater potency. NSAIDs decrease prostaglandin synthesis by inhibiting the action of cyclooxygenase COX. They inhibit COX-1 and COX-2. COX-1 is found throughout the body and is important for control of blood flowing through the vasculature and regulation of platelet aggregation. COX-2 is formed in selected cells as part of the immune response and is involved in the biosynthesis of prostaglandins at the site of injury. Serious side effects are salicylism, hepatotoxicity, and a granulocytosis. Drug treatment for neuropathic pain. When nerves are damaged, the body may make adaptations to compensate for the nerve damage. Reorganization of nerves can cause painful sensations even after limbs have been amputated or injuries are healed. Sensitization of nerve terminals lowers the threshold for neuron firing and increases the response to stimuli. Changes in the sodium and calcium ion channels result in increasing or decreasing levels of ions involved in neuronal firing. Nerve injuries can cause a loss of GABA inhibitory pathways. Drugs used in the treatment of neuropathic pain can include antidepressants like amitriptyline, anti-seizure drugs like gabapentin or lamotrigine, local anesthetics like lidocaine or mexiletine, and topicals like capsaicin. Warnings for drugs used to treat neuropathic pain. They may cause drowsiness. Alcohol can intensify this effect. They may impair the ability to drive and do not discontinue without medical supervision. Tricyclic antidepressants used to treat neuropathic pain. The first choice for the treatment of neuropathic pain, they inhibit the reuptake of neurotransmitters like norepinephrine and serotonin at receptor sites in the spinal cord that are responsible for modulating pain sensation. Selective serotonin reuptake inhibitors are less effective than tricyclic antidepressants. Gabapentin, pregabalin, and carbamazepine are anti-seizure drugs that are used for the treatment of diabetic neuropathy and nerve pain caused by herpes virus infection and trigeminal neuralgia. Topiramate enhances inhibitory effects of GABA in addition to its action on voltage-dependent sodium channels. Lidocaine and mexiletine, both drugs block sodium channels. Lidocaine can be administered either intravenously or topically. Lidocaine patches are indicated for the treatment of nerve pains caused by herpes infections like shingles, not like herpes vaginal or those kind of herpes. These are for shingles. Capsaicin is derived from chili peppers. Capsaicin is applied topically and depletes substance P from nerve terminals. Capsaicin is indicated for the treatment of diabetic neuropathy and shingles. Non-drug treatment of pain. Treatment of chronic pain requires a multi-modal approach, like drug therapy and non-drug therapy, like education, physical therapy, occupational therapy, cognitive behavioral therapy, like counseling, acupuncture, chiropractic, transcutaneous electrical stimulation, like TENS, cryotherapy, cold packs, and heat packs can reduce swelling, which can also reduce pain. Primary headaches include migraine headaches, tension type headaches, cluster headaches, and trigeminal cephalgia. Tension headaches produce bilateral pain affecting both sides of the head, is mild to moderate in intensity, and is described as having a pressing or tightening quality. Cluster headache is a frequently recurring headache. Migraine pain occurs as a result of biochemical and hormonal changes involving in serotonergic and adrenergic pain modulating systems. Migraine and cluster headaches typically affect only one side of the head. However, a migraine can spread to the opposite side. Migraines may be preceded by an aura. Migraine headaches occur more frequently in women than in men. Symptoms for migraine headaches are severe throbbing pain, nausea, photophobia, the eyes are sensitive to the light, phonophobia, sensitivity to noise, physical activity worsens migraine symptoms. Acute migraine attacks can last between 4 and 72 hours. The average is 29 hours. Pathophysiology of migraine headache. Triggers stimulate the release of vasoactive neuropeptides that cause blood vessels in the brain to first constrict and then dilate. Platelets in the blood clump together and cause the release of serotonin, which further constricts blood vessels. Afferent signals via the trigeminal nerve release prostaglandins and other neurochemicals producing dilated blood vessels, inflammation, nociceptor stimulation, and throbbing headache pain. Drug treatment for migraine headache, analgesic, serotonin agonist, ergo alkaloids, antidepressants, beta blockers, and anti-seizure drugs. Triptans are the most widely prescribed drugs for the treatment of migraine headache. Triptans are administered at the first sign of an impending migraine. Triptans are administered during an acute attack to lessen symptoms and prevent progression to more severe symptoms. The mechanism of action, the selective serotonin 5-HT receptor agonist, 5-HT1B and 5-HT1D receptors, which stimulate vasoconstriction. Oral formulations have a slower onset of action. Pharmacokinetics for triptans, the routes of administration that are available are PO by mouth, SC subcutaneously, and intranasal. Subcutaneously is the most rapid response and most effective. Intranasal administration is rapid and has fewer adverse reactions. Oral formulations are rapidly disintegrating tablets. The half-life for triptans is about 2 to 25 hours. Triptans with long half-life, like frovatriptan, naratriptan, are more effective in preventing headache occurrence. So you see that Ha there. If you don't know by now, Ha is the SIG code for headache. Common side effects: pain, tightness, and burning at the site of injection, dizziness, nausea, hot flashes, dry mouth, and fatigue. And then we have our look-alike, sound-alike drugs in the triptans category. Warnings for triptans: do not exceed the recommended dosage. If there's no improvement after the first dosage, do not take a second dose. Do not exceed 2 doses per 24 hours. Non-triptan drugs used in the treatment of migraine headache. There are other acute treatments for acute migraine headaches, like non-triptan drugs. Side effects for these agents may include numbness, nausea, vomiting, chest pain, abdominal pain, drowsiness, dizziness, nausea, constipation, and dry mouth. Migraine preventative therapy is offered to persons that use abortive medication more than twice per week or when acute acting agents are contraindicated or have failed to relieve their headaches.